One, please start. We are live.
Good morning, everyone. This is Pooja Raisam, and I'm very happy to welcome you all today morning on this expert discussion on insights into non-invasive PGTA. So we have Dr. Deepak Goenka and Dr. Sam Balu with us today. So Dr. Deepak Goenka is the director of Institute of Human Reproduction in Guwahati, and he's had extensive training all over the world in USG, laparoscopy, art, and genetics in institutes like AIMS, SGPGIs in Singapore, Australia, UK, and USA. Having performed IVF since 1997 with more than 200 endoscopy procedures per year and more than 25,000 IVF cycles so far, he's trained more than 500 specialists in techniques like IUI, IVF, and ICSI, and he's successfully running a one-year fellowship course in reproductive medicine. He's currently the president of the Guwahati chapter of ISO PARB from 2021. Welcome, Dr. Goenka.
Thank you, Pooja.
So we also have with us today Dr. Sam Balu, who's the General Manager of Genomics at Lilac Insights Private Limited. He's done his PhD and postdoc in human genetics from NIMHANS. He has hands-on experience in genetic testing from cytogenetics to microarray and next-generation sequencing. And he's worked across India, helping set up support and validation of facilities for PGT services. And he has 6 publications and co-authored a chapter in a book as well on the genetics of autism. And he's also selected as the subject matter expert for the special interest group on applied genetics by IFS in 2021 and 2022. Welcome, Dr. Sam.
Thank you, Pooja. Good morning, everyone.
I now would like to hand over the session to Dr. Deepak to take this forward.
Thank you, Pooja. Good morning, everyone. In the first, I would like to thank Dr. Sam and Lilac for joining this session, for accepting our invitation. I do understand this is a very, very new field, and very few of us are practicing this. We have started doing this non-invasive PGTA since November, somewhere in the November 2021. And so far, more than approximately 100 blastocysts we have done. And had a fair experience of ups and downs about this technique. So I thought this is the right time to discuss with the expert, Dr. Sam. We are troubling him since last 4 months. Every week we are troubling him with some queries or some other queries, some new issues are coming up. So many of our doctors in the Institute of Human Reproduction have so many queries we have discussed so many times. So I thought it will be nice to hear what queries we have and what answers our expert gives. Dr. Sam, thank you for joining this session and thank you for accepting our invitation.
At the outset, Dr. Goenka, it is my honor to be part of the discussion with such a learned expert such as yourself. And although it is very nice to say that, there is never any trouble when discussing with you or your team, because for me, it has always been a very enriching learning experience, because ultimately it is you who face the patient and help them become a parent. It's a very noble thing indeed. And it's my pleasure if I'm able to contribute to that in any way. So with that, sir, I would, can I start my presentation?
Yes, please. In fact, let me tell you about this whole session to everyone. Whatever queries we have come across in last 6 months, in fact, I personally am reading about this non-invasive technique of PGTA since last almost 2 years. 2 years back in one of the meetings, I heard about this topic, and we are doing PGTA since more than a decade. Earlier we were doing the blastomere trophectoderm biopsy, and now we shifted to this NICS. And there were talks, did we shift much before time? So whatever questions we had come in our mind in our last 6 months, I have forwarded the questions to Dr. Sam so that we can have some evidence-based answers, some authoritative information about the issues. So Dr. Sam, can we start our PowerPoint presentation?
Yes, sir. So I just shared my screen. I hope it's visible to everybody.
Yes, Dr. Sam.
Yes, doctor.
So one of the
So-
major questions, sir, would you please start
Yeah.
off?
Yeah, the first question which I'd like to ask Dr. Sam, why to do PGT? Why to take this hassle? Why not to transfer directly uh, uh, embryos either to 8-cell or blastocyst? Why to take hassle of doing this PGTA?
Yes, sir. So essentially here, sir, I'd like to answer that in two ways. One is that PGTA is an optional screen for aneuploidies. As we know, the IVF process does result in embryos which may look morphologically good, but still harbor aneuploidies, and aneuploid embryos on transfer have poor pregnancy outcomes. So this is a method for screening, and it uses the genomic DNA. So you're taking DNA from the embryo itself and checking it for the chromosomal ploidy status. And typically nowadays it is pretty much restricted unless it's a critical case to trophectoderm biopsies where you're looking at the trophectoderm. So this is one of the major reasons for doing this. The indications for that, if I may, sir.
Yeah, please.
So the indications for that are typically recurrent implantation failure, advanced maternal age, certain male factors, and in case parents are carriers for chromosomal rearrangements such as balanced translocations. These are typically indications for PGTA in the past, and now for most of these, non-invasive PGTA also can be offered.
Dr. Sam, just go back to the previous slide just for 1
Yes.
second. Previous
Yes.
to this also. So what I understand here, we are doing PGTA just to improve the implantation
Correct.
and to decrease the abortions rate.
Exactly.
Right? To translate this your slide into a simple clinical language.
Mhm.
So to improve the implantation and to decrease the abortions rate. Right?
Exactly, sir. Exactly.
Right. So going back to the next slide,
Yes, sir.
we understand the few indications you have mentioned here.
Yes, sir.
When we were doing this PGTA for certain of our patients, one of my colleague from Hisar, Dr. Preeti Mund, she asked me the question, sir, why not to do in this all cases?
Right.
I think this was my next question to you.
Exactly, it was.
This question was asked to me by
Yes.
Dr. Preeti Mund from Hisar.
Correct, sir. So
Right.
one of the major problems in doing PGTA is that it's invasive in nature, sir. So you're invading into the embryo, and there is certain trauma. The embryo will recover from it, no doubt. But there is certain trauma caused to the embryo. You require a laser, and you're actually exposing the embryo to laser while sampling. So this is one of the major drawbacks of that, and it requires a certain level of expertise so that the biopsy is done and the tubing is done properly. So the entire process should yield in a result. So we want to do a biopsy for an embryo so that we get a result about its ploidy status. To get a result, the best possibility is when we have an expert who can do a very, very sensitive trophectoderm biopsy where the embryo is not exposed, there is not overusage of laser and other things. And recently, one of the major literature reviews has shown that embryos which undergo trophectoderm biopsy have a higher risk of monozygotic twinning. That is why even now in the clinical practice across India and pretty much across the world, it is quite selectively used. And I think that's where we feel, me as a geneticist feel that if we are able to have a non-invasive option, then it becomes far more easier to apply it as a routine screen than something which requires a laser, requires invasion, and requires a biopsy to be done.
Dr. Sam, I would like to add one more thing here.
Yes, sir.
As a clinician, what we face in our day-to-day clinical practice, this adds added expenses.
Exactly, sir. Exactly.
So already we always struggle with the expensive procedure IVF, and we have to pay for each and every blastocyst. It's not that it comes in a package, and these expenses are carried forward to the patient only on the last moment, because till the last moment we are not sure how many blastocysts are going to form.
Yes, sir.
So this becomes another challenge.
Yes, sir.
Right, Dr. Sam. Our next question will be, what's the ideal way to do an PGTA? How it should be done? Whether we should do it at the 4-cell, 8-cell stage, trophectoderm biopsy, how it should be go?
So if you look at global literature, Dr. Goenka, and if you look at the good practices, and good practices in terms of which gives us the most likelihood of getting a proper answer. By and large, I think there is a consensus across the world that now trophectoderm biopsy is the first choice. The blastomere 8-cell stage biopsy is only reserved for critical cases where we don't have a choice of doing a trophectoderm biopsy. Either the patient is insisting on doing a fresh cycle transfer itself rather than a frozen cycle. Only in very few cases it is done, and more often than not trophectoderm biopsy. And there are certain advantages and disadvantages in doing a trophectoderm biopsy. One of the advantages is simply that as a geneticist and as a service partner, we end up getting more DNA to work with. It's a bigger representation of the embryo because we typically get between 5 to 8 cells in a trophectoderm biopsy. So the likelihood of it being a failure is quite low, below 4%. And the same biopsy can be used for monogenic disorders as well as structural rearrangement. However, the disadvantage, the other side of the same coin, is that there is no representation of inner cell mass in a trophectoderm. What we are doing is testing essentially the trophectoderm, assuming concordance between trophectoderm and inner cell mass, and then making a call on whether this embryo should be used for transfer or not. And there is a lot of literature which has come to the forefront that trophectoderm cells or the trophectoderm layer tends to harbor more a quantity of live aneuploid cells, because it's not going to be the fetus post-implantation. It's going to harbor more live aneuploid cells than the inner cell mass, leading to a higher false positive rate in PGTA.
What I understand here, usually when we do CVS, we talk about 0.5% to 1% mosaic between the placenta and the fetus.
Correct.
So do we have any percentage that what will be the incidence of mosaic between the trophectoderm cell and the inner cell mass? Do we
Yes.
have any data on this?
So there are some publications by Victor's group. This is the Spanish group, where they've seen a discordance of around 3% between the
Okay.
ICM and the trophectoderm. And when it is mosaic, it goes all the way up to 7%.
Okay,
So
so
you have mosaic calls.
this is a very, very important information. So with the trophectoderm biopsy, we may have a mosaic rate of up to 7% and discordance rate of up to 3%. Am I right?
Yes, sir. You do.
And now it's a era where we are offering NICS, non-invasive screening methods we are offering, or what we call non-invasive PGTA. So what are the different ways of doing it? Do we have different ways?
Yes, sir. So currently, all non-invasive PGTA is next generation sequencing based. So when you come to something like a trophectoderm biopsy, you still have microarray available. Whereas since we are looking at cell-free DNA and it is highly fragmented DNA, currently the only methodology used across the world is next generation sequencing. There are various chemistries or kits available for doing non-invasive PGTA. There are kits which we use, which are with our partner Yukon Genomics. There are kits from PerkinElmer which are available. There are kits from Cooper Genomics which are available. There are whole different things. But pretty much, Dr. Goenka, what happens is the process or the flow of the sample in terms of processing is not significantly different. What is different is the approach taken to certain steps in the process. So for example, one of the most critical steps here is whole genome amplification, because what we are dealing with is cell-free DNA, which is already fragmented and in very low concentration. So in the media, you will have between 15 picograms to 20 picograms per microliter concentration. This is considering it's an expanding blastocyst. If it is not expanding, it will be even less. So what is the current application of this is using NGS, we're able to sequence it, generate data, and using particular software, we're able to give a call on the ploidy status as well as percentage mosaicism. So that is possible. And there are a variety of kits in the market which can be used. We have chosen to use the Yukon Genomics because it offers certain technical superiority for us.
Thanks, Jamak. In fact, you have answered my next question partially.
Yes.
Let's try to explain our audience what is the flow of the NIPGTA from the clinician, from the embryologist point of view, and going to back to the laboratory point of view. That this is, I think, is my next question.
Yes, sir.
How PGTA done? Can we just explain our audience the flow?
Sure, sir.
Yeah.
It's a very, very simple procedure, especially for embryologists we work across India. They find it to be very simple. So typically a profectoderm biopsy can last from 30 minutes to a few hours because we have to give a laser hit, wait for the profectoderm to herniate to around 10% to 15% before we do the biopsy. Whereas here, the entire sample collection process happens in minutes. So you can collect anything between 1 to 4 sample in maybe 15 minutes to 20 minutes. Very, very simple. What we have to do here is once the blastocyst is expanding and it's ready for vitrification, transfer that embryo to vitrification, then quickly collect the media and add it to the tube. Once that is done, the samples are frozen and then they're transferred to the lab in dry ice. Then we take them to the lab. We take the media, remove whatever oil is there, which has come along with the media. Then we do a pre-PCR and a whole genome amplification. And Dr. Goenka, that whole genome amplification step is critical in determining the success of the sample. Once we do a whole genome amplification, then it undergoes the typical, any NGS sample undergoes certain steps. So there's something called a library because NGS systems are high throughput systems. We have to run batches of samples. So we don't run a single sample. So in that, what we do is we organize the DNA fragments, label them and give them barcodes so that we are able to identify which sample, what data is being generated. Then we do NGS sequencing. Currently, it is done on an ion S5 and ion proton system. And then we do primary analysis. So there are several layers of quality check in the process. So once the raw data is generated, you have a first level QC. And the software we use for non-invasive PGTA at Lilac Insights is called ChromeGo. So that is the algorithm which we use for aneuploidy analysis. So once we have the data ready, it goes to ChromeGo, analysis happens, then reporting and curation is done manually by a team of experts, including myself. And then the report is shared with you. And post-reporting, we of course offer genetic counseling because any genetic test is highly contextual and it changes from case to case. So this is the typical workflow for the non-invasive PGTA.
Thank you, Dr. Sam. It looks pretty complicated for me. From my side, it looks simpler. For my job is, as an embryologist, it will be much easier to collect the sample and send it to you. May we explain them how long it takes?
So currently, sir, it takes once the samples come to us. At present, it is taking 21 working days for us. So that excludes holidays and weekends. It takes 21 days for us to give you the report because the process is itself a long process. We have to build a batch, multiplex it, process it, and then we take a little time. So we spend a little more time in ChromeGo analysis so that we are very, very sure about what we report because it's all about making sure that this precious pregnancy gets established for the patient. So what we do is we have an AI module in ChromeGo and we, on top of that, we add an additional layer of expert analysis. So some margin calls, some reanalysis is required. That all takes a little more time. And that's why we are very confident about our reporting.
Right, Dr. Sam. I will share one personal issue with this turnaround time. What happens usually, we take the collect the sample, spent media, what we say, where the embryos, where the blastocyst grows. That media, usually we call it as a spent media. Once we collect and send the spent media to you people out there in Lilac, after that, as you told us, it takes almost 21 working days, which is practically 1 month, with all Saturdays, Sundays, and holidays, national holidays, state holidays. It is practically 1 month. And patients usually get their menstruation 10 days or 15 days after the pickup. And for another 15 days, we don't get the report. 15 days after the collection of the media, they get the menstruation. Another 15 days, they don't get the report. So practically in the immediate next cycle, we are not able to do the transfer.
Okay, sir. Okay.
First cycle, we did the pickup. Then we have to give a gap of 1 cycle. Sorry. Then in the third cycle, we have to plan for the transfer. Hopefully in future, we will have a little faster this step so that we don't have to waste in between 1 cycle. But this is just a feedback to you, but practical problem we face.
Correct. And I completely understand, sir, because like I said in the outset, you are looking at the patient, you are looking at the establishing the pregnancy. I understand that, and I would be very happy that to share that, from the month of May, the reporting TAT for Surety, which is our NICS process, is going to be reduced. The exact time of reduction right now, I'll not be able to tell you, but we have worked on certain automations in the process also to bring down the TAT further. And I'm sure, Dr. Deepak, that we would be able to match your expectations, because for us, it's all about delivering answers to you in time. Like you said, if the patient has to skip a cycle, it wastes that one cycle. That opportunity,
Yes.
even we also don't want the patient to go through or miss it. So I would assure you that I would work with you and bring down the time so that it matches your expectation and the patient.
Thank you, Dr. Sam. That's a great news. Uh, you have used a word again and again about the amplification.
Yes,
What do you mean by DNA amplification exactly? Why do we need to do that, and how do you do it?
yes, sir. So this is just a slide on sample collection, and I'll skip this, sir. It's not that much info. It's a lot of information, and since we have talked about.
Wait a minute, Sam. This is a very important slide. In fact, I was not aware of this information. We can use this technology even for the frozen embryos.
Yes, sir, we can.
So after the freezing, we can just thaw the embryo, the blastocyst, and we can again culture it for another 24 hours. Or if we have leisure, we can give a sort of breach the zona, and we can, after 6 hours, we can send you the spent media.
Yes, sir.
So this is a very, very important information for all the embryologists and the clinician,
Yes,
that if we have not planned NICS or PGTA beforehand, and if we have done freezing to these blastocysts, we can use these blastocysts, and again we can go ahead with the PGTA.
Yes, sir.
Not necessarily you have to plan today only, and from today onwards you have to plan. If we have old our embryos, even in those cases this can be offered.
Yes, sir. And we have done it across India, where day 5 samples have been sent to us and we have been able to report them. And as you can see, sir, there is no preference in media. So one of the things why we partnered with Econ and why we customized this is, we don't want the center to radically change its culture protocols. So that is the approach we took, that because you are having success with your established methods, just because we want to do a genetic test, it should not disturb it. So that is one of the approaches we have taken.
That's really very, very comfortable for all the embryologists, all the clinicians.
Thank you so much.
Yeah, I think we can move forward to the next.
Yes, so why DNA amplification is so important, and I repeatedly talk about whole genome amplification. So whole genome amplification was not originally designed for cell-free DNA. Its application was in single cell sequencing of DNA. Later, it was also used for cell-free DNA, and whole genome amplification is pretty much a PCR-driven process. It is currently used both for single cell DNA as well as cell-free DNA analysis. And very important, Dr. Deepak, to understand, whole genome amplification is random DNA amplification. So it is not like a traditional PCR where you have primers which target one particular region and then amplify it. Here what happens, it is random amplification of DNA across all the chromosomes in the genome. But whenever you're choosing a method for whole genome amplification, we as geneticists think about 3 things. One is how good the coverage is across the genome. Because if I'm looking at PGTA non-invasively, I need to have representation of DNA from all the 46 chromosomes which are there. So I need good coverage. Then I need to have good fragment length. Fragment is how long of a read I get in DNA. After PCR, how big is my product? And what is the error rate? Error rates are also very important, because if the PCR has very high error rate, there are certain applications you cannot use it for. So I will just quickly show few different methodologies and what we have chosen at Lilac Insights. So you have various methods of doing this PCR, whole genome amplification. Currently, we are using the third one, which is called Malbac. We partnered with Econ because Econ is the company which developed and patented Malbac. And later on, based on Malbac, the Picoplex came. So you'll see a lot of companies who talk about Picoplex in their reports. So Picoplex is a derivative of Malbac. You got very good coverage of the genome. You have very low error rates in this PCR, and you get decent size fragments. The fragment is too small, then it hampers the library preparation. If the PCR error rate is too high, as you see in DOP PCR, it can only be used for certain applications. But then I have to switch the technology if I have to do something like a PGTM with them. So that is why we have chosen Malbac. That's why we partnered with Econ. This is critical because this determines how good the DNA is available for library preparation and then sequencing. So poor whole genome amplification results in poor libraries, and then that will inevitably lead to failure of the sample. So this is the critical step.
This definitely looks little complicated, but what I understand, basically in the spent media, we have a very little amount of the DNAs.
Yes, sir.
To analyze them, we have to have a replication of these things. And this is why basically we need whole genome amplification.
Exactly.
And we have different techniques. And just now very nicely you have explained which technique we are using and how we are using. Yes. In between, I would like to tell to Chirag. Chirag, I'm getting message from the one of the, in fact, from the two persons that they are not able to log in. And I have forwarded the message to Kunal also, what message I got. I think they are getting some message, an error occurred. Please try again. Playback ID GW. Some message is coming to some of the delegates who are trying to log in. Just have a look from your technical team. And I think in between we can move forward, Dr. Sam.
Sure, sir. Sure.
Next, I would like to understand, can we really do sufficiently, do we get sufficient DNA from the spent media? This is just an extension of the whole genome amplification only, because this question comes again and again. There is a segment of the scientists who repeatedly question the validity of the NIPGTA, that we don't get sufficient DNA. So today, in April 2022, do we have our genome amplification technique good enough that we can amplify them and we can get sufficient DNA from the spent media?
So in a nutshell, Dr. Deepak, yes. Because if you look at it, whole genome amplification is typically designed for single cell DNA. And in the case of the embryo, we are talking about a multi-cell stage. So definitely there is enough DNA coming from the embryo, and the whole genome amplification, the Malbac PCR is sensitive enough. It even works with low concentrations in picogram trace DNA in the media to do it. So typically we are able to give results for most of the samples. Currently for around 3.5 to 4% samples, we sometimes find insufficient DNA for analysis, but that is the exception and not the rule. So typically we are looking at with more than 700 samples done, we are looking at around an average failure rate of 4%, which is comparable to PGTA. In fact, with your permission, Dr. Deepak, I would like to discuss a case where the same doubt was there with one of our clinicians from West Zone. So she was saying, Sam, it is difficult to get DNA in biopsy itself because we are taking only so few cells. How are you saying that in the media, there is enough DNA for you to not only test, but even report? So she said, I am not very convinced, Sam. We will do one thing. We will do a comparison. I will give some embryos, which I'm doing biopsy media. I will give it to you. We will do the biopsy elsewhere. And in fact, what happened in that particular case is for 2 of the samples, PGTA failed, but non-invasive PGTA worked. We were able to report.
Right. Sam, I would like to share our experiences also. In last 4 or 5 months, we have sent you approximately 100 samples. And I can recall 2 samples where you have given us the report, DNA not sufficient.
Yes, sir.
And in both the cases, we have done PGTA, blastocytorectoderm biopsies.
Yes, sir.
And as far as I can recall, 1 blastocyst was normal. So
yes,
out of 100, we had a failure rate of around 2%.
Yes, sir. And the other one was, I think, an aneuploid call, if I remember correctly.
I'm not where, I don't remember exactly. Yes, yeah, so I think one was euploid and one was aneuploid.
Exactly, sir.
Right.
So that is how it works, sir. And we don't, we don't at LILAC classify as no DNA, because there's always DNA. Only thing is it is sometimes insufficient for analysis.
Insufficient for analysis, right. Thanks, Dr. Sam. Can we do something to decrease the incidence of this 4% to further less? There are some embryologists which used to say, if we take out the spent media just around the growing blastocyst, we may have better DNA collection. Is it true?
So, sir, where we should collect it from is always a debate, but it's a media. And typically what we are recommending is, for both of us, the criticality is the embryo. and we should avoid putting the embryo into any kind of shock. So typically, in our own experience, the major thing is that anywhere in the media, if you're taking it, please mix it. So, and typically what we recommend is post vitrification of embryo also media can be collected. Post vitrification also it can be collected, but very important is that DNA does form a gradient in the media. So if you are not mixing the media gently 2 to 3 times before collecting it, there's a chance you will not get it. And other experience which I have not had from your institute, Dr. Deepak, but other institutes is they will give me very, very little media to work with. So I have worked with even 5 microliters of media, whereas our requirement is around 15 to 20. 5 microliters of media, we have reported in it, but we have to understand the trade-off in that is it becomes noisier. The data starts to become noisier. In fact, even in our insufficient DNA calls, it's not that we have not got data. Only thing is the data is so noisy that we are not able to analyze and interpret it. So this is another big problem. And of course, I will be talking about how contamination comes. The trade-off in having such a sensitive methodology is that it is equally sensitive to contamination as well. So in terms of where I can collect that from the droplet, I think it is very important that we mix it and collect it. Another question which you asked me before this, Dr. Deepak, is how do we reduce this failure rate? One thing we have done is we have worked with across centers. Some centers are doing well culture, some centers are doing micro droplet culture. Typically between 30 to 50 microliter droplet for culture, we are able to get good results. Going above that, maybe 100, 150 microliters, there what happens is the concentration of DNA, picogram per microliter of media, starts coming down. And that is one thing we just need to be careful of. Although I'm working with a few centers in India who are planning to give me 100 from 100 microliter droplet culture. So once I get those results, I probably would be able to update on that aspect. But that is also something we are working.
Sam, let me share about little bit about myself.
Yes.
I am a trained embryologist. I have worked in the laboratory for years. Now I don't go to the laboratory very often. But I feel what you are telling is very important for every embryologist. If we standardize the thing, life becomes much easier. There are less chances of error and more chances of successful analysis. As you told, 40 micron, 30 to 40 micron media, if we start culturing our embryos into the 30 to 40 micron of the media a week, and out of that 20 micron if we send it to you, that makes it very, very standardization of the thing and less chances of error, and you are more comfortable and we are more comfortable in having more results, more successful results.
Yes, sir.
So this type of standardization is very, very important when we are going forward for such a high-tech technologies. Right.
Yes.
Coming to the next question. Suppose you have sent us the report, media DNA is not sufficient. What next? Can we do something about it?
Definitely, sir. What do we say? What do we take up? So what are my recommendations is, one is, because right now on day 5, you are giving me the sample. So inevitably it is frozen. You can you can take up the approach of redoing it with non-invasive itself. You can thaw the sample, allow it to expand, do the laser hit 6-hour culture and give us a sample again. We had few cases like this where second round of non-invasive PGTA in fact has given results. However, the alternative is to look at whether you want to go for a trophectoderm biopsy. If the center is already having experience with TE biopsies, then that can be taken up, as we discussed recently, Dr. Deepak, for the 2 cases.
Yes.
So those 2 cases, yes, we can go for a biopsy and look at it, especially if you're finding that the embryo is not expanding quite well, or if it's a low-grade embryo, but we want to consider this for transfer, then you can look at a biopsy. If it's an expanding blastocyst, which is quickly expanding, a second round of non-invasive PGT also can be done. I would like to add a little bit here, Dr. Deepak, that abroad, certain places in Asia, even for PGTA which fails, the second round is now becoming non-invasive PGTA.
Right.
Trophectoderm biopsies which give insufficient DNA or no DNA, in certain hospitals abroad, the second time they are not going to do a rebiopsy. In fact, they're going for non-invasive.
I am sure, Dr. Sam, this will be the trend here in India also. Don't worry. It will be very soon, as we will be more standardized in the things. It will be a norm here in India also.
Yes.
Now, this is very important information you have given us. Let's not consider let's not consider to discard those blastocysts which did not give us sufficient DNA. There are alternatives. So don't consider them as abnormal.
Correct, sir.
They are not abnormal always. They may be normal, they may be abnormal. Try to do resampling. Either by, if you have expertization of a TE biopsy, let's go ahead with the TE biopsy. If we don't have expertization of TE biopsy, we can again rethaw them and refreeze them, and rethaw them, culture it, preferably with the laser and Jonah breaching with the laser, followed by 6-hour culture, and we can refreeze it and we can resend the spent media for the analysis. So let's not discard them thinking that they are abnormal. That's why they did not give us sufficient DNA. That does occur, but we can. There are ways where we can move forward.
Exactly.
Right. Let's go ahead with our next question. For now, with the advent of non-invasive PGTA, do you think it is important for all embryologists to know about the TE biopsy? As you told in your first slide or second slide, one of the limitation factor of the PGTA is expertization of the embryologist. So now, after the invent of this non-invasive technique, is it necessary for everyone to know about the trophectoderm biopsy?
So a very, very important question, Dr. Deepak. So across India, you have a lot of embryologists who don't have hands-on experience in doing an embryo biopsy. But the important thing here is no prior experience with PGTA is required to do this, because it's a simple media collection. However, there are certain good laboratory practices which need to be followed even while doing non-invasive PGTA. So to do a biopsy and tubing, there's a great deal of expertise and training which is required. But to do non-invasive PGTA, still some good practices need to be followed. For example, the day 3 wash of the embryo, in case there are any residual cumulus oophorus cells, that needs to be taken up. Using things like filter tips for media collection to avoid crossover contamination, and setting up the dish with appropriate controls. So we mandate 2 controls. One is a dish control, which is there in the culture dish, and the second is a fresh media aliquot. And sometimes what the doctor will say is that, Sam, look, we don't get contamination. But for us, we are talking about trace DNA coming anywhere other than the embryo. So although no prior experience is required for with PGTA or doing a biopsy, for doing non-invasive PGTA, there are certain quality control measures which should be implemented while sampling for non-invasive PGTA.
So basically, even from the granular cell, we don't want any DNAs, right?
Correct, sir. Even cell debris, sir.
Yeah. So message to all embryologists, denudation has to be complete. Let's not leave behind even a single granular cell when we are doing denudation. That's very, very important. Moving forward, we were talking about the amplification of the DNA. How do you analyze? I think you have answered that. How do you analyze the DNA?
Yes, sir, I have.
Yeah.
Yes, sir, I have answered it. More, I can just quickly elaborate on a couple of points, especially in terms of quality checks. Right. So we have multiple layers of quality checks. So post-sequencing is where the quality check happens. Pre-sequencing, we have a library QC, which tells us that the concentration and the library of this DNA is good quality enough for sequencing. Those go into sequencing. If not, it goes back. We go back to the sample, do whole genome amplification and re-prepare the library. Happens in less than 1% of our samples currently. Most samples qualify for sequencing. Post-sequencing, first we see that NGS sequencing has happened properly. Before we even start data analysis, we make sure that the run QC, so NGS run or sequencing QC is proper. If the sequencing QC is proper, then only we will go for actual data analysis. So once we do the data analysis, this ChromeGo software has 3 separate QC parameters before it says the sample is euploid, aneuploid, or mosaic. It looks at 3 different quality parameters, essentially valid reads. This is something which we put in the end of our reports. The second thing is the GC coefficient and the coefficient of variation or distribution of data across the sample. These 3 parameters ensure that what data we are analyzing is good quality data, represents the entire genome of the sample, all the chromosomes, and that we have enough distribution across the various parts of a chromosome. So no part is either having too much data or too little data. After it does these 3 quality checks, only then does it go for actual calling. And the ChromeGo has an AI module, an artificial intelligence module, which is used for calling. So based on data and statistical data, it will determine if this sample is having any aneuploidy, if it's a mosaic aneuploidy or a complete aneuploidy, and then gives us a result. With that, as experts, me and my reporting team will take up the data, analyze it on a secondary level, look at the context of the case, analyze it on a secondary level. For example, if I'm looking for a particular translocation, I know that even a mosaic, a slightly higher mosaic call on a chromosome involved in the translocation should be flagged as an aneuploidy and not as a mosaic. So that way, we do a secondary or tertiary analysis over here, and then we release the reports.
That's amazing, Dr. Sam. That's really amazing. So much of work goes behind scene, and many times we don't even realize. One more word I come across very frequently is validation.
Yes,
Usually, we clinicians don't talk about this validation. What do you mean by validation? Why do you have to do? Why all the geneticists, all the lab scientists talk about the validation?
So validation is very critical for any genetic service, because that shows that this is a proven technology, because we are using it in a clinical context and not a research context, and clinical decision making is based on the outcomes of this result. So having validated technology and validated technology in a laboratory setting as well as a clinical setting is critical for us. So here, when we have partnered with Econ, before we partnered with them, we had several rounds of validation. What we did is we looked at first their own data in terms of clinical context. Have they used this in a clinical setting? Is it validated clinically? And what do we mean by validation? The endpoint of validation is a peer-reviewed publication. So for us, it's only validated when it is peer-reviewed by the scientific community, by clinicians. So they had peer-reviewed published data in support of their technology and methodology. Then we adopted it. Still, before we came to the clinician in India, we ran several rounds of validation. So we had genomic DNA validation, which made sure that whatever we are reporting today comes only from the sample and not the process. So very important is that the lab needs to have a validation being done at the laboratory to make sure that process does not influence outcome. It is purely sample. So we got 100% concordance with our genomic DNA. So I took genomic DNA, which was known to be aneuploid and euploid, confirmed with microarray as well as NGS. We ran those samples using the same NI-PGTA technology, which we are offering commercially today. And we got 100% concordance, 100% true positive rate, 100% true negative rate in those particular samples, 0 false positives or false negatives. Then we bought it commercially. There also we did a lot of validation. Another important thing, Dr. Deepak, is very often clinicians say, Sam, what is the concordance between non-invasive PGTA and PGTA?
Right.
That is because everybody is used to PGTA. Very few people have taken up non-invasive PGTA in India. Very important is we should understand that although they are similar, they are not the same. Because in PGTA, you're looking purely at the trophectoderm, whereas in non-invasive PGTA, you're looking at both DNA from trophectoderm as well as inner cell mass. And studies, even Econ's own published studies, show that when you look in the context of the whole embryo, non-invasive PGTA routinely outperforms PGTA. Especially trophectoderm biopsy PGTA, it routinely outperforms. So I think...
Yeah, please continue.
Yes, sir. I'm so sorry, Dr. Deepak.
No, it's all right. Please continue.
So this is the publication from Econ Genomics and their team. And this is a 2019 paper, quite a recent paper, where they did a comparative analysis between PGTA, non-invasive PGTA, and then the embryos were sacrificed. So if you look at this, this is 52 embryos in this study. They used a high percentage, 60% mosaic to report. And routinely they found that non-invasive PGTA actually is a better representation of total embryoploidy compared to PGTA. One of the most striking things in this particular study is in that first line. The false positive rate in non-invasive was around 20%. So you had a call where the embryo was euploid and you had a aneuploid call in only 20%. Whereas in trophectoderm biopsy, it was 50%. Half those embryos which were actually euploid were flagged or called as aneuploid by PGT. It is a big difference. And what does that mean to a clinician? It means I have half the number of embryos available for transfer. And unfortunately, for some patients, this may end up being that no embryos available for transfer at all. That is one of the big features in non-invasive PGTA. And when you look at the whole embryo biopsy, the aneuploidy calls, the chromosomes involved in the aneuploidy, everything, we get much better data and information from non-invasive PGTA as compared to PGTA.
This is a very, very important information, because I can recall from our own experience when we were doing the trophectomy biopsy, we used to get a lot of cases where all aneuploidies. Now the incidence of getting all aneuploidies are much lesser. I can vouch for this study, but what we require at this moment is a bigger studies. I can see the sample size numbers are still very limited. Hopefully, we will in the future we will have a better studies with a better numbers.
Yes, sir.
I deliberately.
Sorry, sir.
Yeah, please.
One of the major problems in this kind of study is that those embryos need to be sacrificed.
Yes, that was one of the important thing in my mind. Yes. How can we do that?
Yes, sir. Because once we touch the ICM, the embryo is not suitable for transfer. And in all these papers, whether it's Shitara's paper, Wang's paper, all these papers, embryos are sacrificed. Generally, these embryos are being volunteered for the study. So that's why you see that we don't have a large multicentric study where you have embryos being sacrificed. We have small studies like this currently.
Dr. Sam, I am just thinking loudly. Yes, now we have a ART law.
Yes, sir.
And in this ART law, extra embryos we are not supposed to donate to someone else.
Oh.
Either we can discard them and we can use them for the research purpose. Maybe we can utilize these embryos for this type of studies.
Absolutely.
When the couple doesn't want to continue to carry freeze these embryos, they have successful deliveries and they don't want to continue these embryos further. So we can utilize those embryos for this purpose. Earlier, what we used to do, couple used to give us consent to donate to someone else. But as per the latest law, we cannot do that. The couple cannot do that. Until and unless there are some changes in the law, I think this is one of the way we can utilize and we can come up with a bigger number.
Correct, sir. And that is critical because what is the main thing is there is a misconception in the market that non-invasive PGTA should match PGTA. Although we have around 96% concordance between PGTA results and non-invasive PGTA results, 3 to 4% discordance is there, where we get a varied call simply because here we are seeing a mixture of trophectodome and inner cell mass DNA, where there we are looking purely at trophectodome, assuming concordance between trophectodome and inner cell mass.
So very, very rightly said. And let me tell you, why did I ask you this question? Because again and again, it was asked to me, did we switch to NICS much in advance? So I was convinced, I was reading about this technology since last 2-3 years, as I told you earlier. Yes. So I was very, very convinced. As soon as Kunal came to me and offered me, I just jumped to it. I was waiting for someone to take up the call. And as soon as Kunal came and we were with you. Yes. Thank you, Dr. Sam. Let's move forward.
Yes, sir.
Next, let's go to the next question. Next slide.
Yes, sir.
Right. Regarding the apoptosis, yes. Many times I hear that spent media contains more DNA from the apoptotic cells.
Yes, sir.
And which are more aneuploidies. So is it true? Before answering that, I would also like you to explain what is the meaning of apoptosis and what are the apoptotic cells?
Sure, sir.
And does more cell-free DNA comes from the apoptotic cells? Is it true?
Yes, sir. So to answer your question, apoptosis is nothing but programmed cell death. It is a completely natural phenomenon in any developing embryo. So comparatively, the apoptotic cells. So if you look at an aneuploid cell and a euploid cell, apoptosis happens in both. So you have apoptosis happening both in euploid as well as aneuploid cells.
So nothing like that. Aneuploid cell will have more apoptosis.
So, sir, generally what happens is if there is a large number of aneuploid cells in the embryo self-corrects and tries to clear them out preferentially. And interestingly, if you look at this paper from Bolton, what they say is this clearance happens selectively at a higher rate in the inner cell mass than the trophectodome.
Right.
if you look at this here, sir, if you see that it is 41% in inner cell mass and 19.5 or 20% in the inner cell mass compared to just 3.3% from trophectoderm and 0.6%. So, yes, sir.
Sam, sorry to interrupt you here.
Yes, sir.
This creates another confusion in mind. So that means many times embryo may be normal because of the self-correction, but the spent media will show more abnormalities. Am I right?
Exactly, sir. Exactly. So this doubt always happens with most of the clinicians who I interact with. Interestingly, our euploid call rate is the highest. Euploid call rate for our 700 plus samples is around 42%. So even this doubt was there, Sam, the embryo is normal, but abnormal cells are undergoing apoptosis, so you'll get aneuploid calls more. In fact, it is euploid calls followed by mosaic calls, followed last by aneuploid calls. So the aneuploid call rate in non-invasive PGTA with us is around 20-25% only, whereas the euploid call rate is 42%.
Okay.
So most of these embryos where we get a very good amount of DNA and we are able to give euploid calls followed by low-level mosaics. And we'll be talking about mosaicism soon, Dr. Deepak. So there. So it is euploid, mosaic, aneuploid, even for non-invasive PGT.
Right. Let's move forward. Another questions which comes.
I will just just a quick thing. I will not take more time on this. So people also sometimes ask, are you sure? How does the DNA get out of the embryo? This paper is a very beautiful paper. I think it's a wonderful thing because they were able to visualize the trafficking of this DNA. So they were actually able to track it using electron microscopy, how the DNA is coming out from these cells into the blastocelic fluid and from there into the media. So this is another paper which shows this, which actually is proof that the inner cell mass as well as trophectoderm undergo apoptosis both in euploid and aneuploid cells, and they traffic them out actively. Closer to day 5, higher these vesicles are seen in the media. That's why we recommend day 5 sampling.
Yeah, that's a very important information why we should go with the day 5 sample only. Another thing which we worry about the contamination. Exactly. What about the maternal cell contamination and granular cell contamination and other debris? I think you have told a little bit more about it. Let's have a little bit more information about it.
Sure, sir.
Important information. Why I am asking you this question? This is a major limitation. Sometimes we have embryos where we have done the IVF, not the ICSI. So is it possible currently today to go ahead with the NIPGTA following IVF?
Yes, sir. So unfortunately, Dr. Deepak, the response for this particular question is trace DNA contamination is a problem. Even low quantity of trace DNA becomes a big issue simply because whole genome amplification is designed for such low concentrations of DNA. Any DNA left behind in the media from any cell, it could be a cumulus oophoros cell, or it could even be residual sperm DNA, which is adhering to the zona, will contaminate it. In fact, I did a study in Hyderabad with a center where they sent me 12 cases of IVF embryos. We were able to report it, but the data was noisy in IVF. Compared to ICSI, the data in IVF embryos is currently noisy, but it was a very small sample size, only 12 embryos, because they were not able to give me more embryos. So if you would like, sir, we can have a batch where you're sending me some IVF embryos and that can be tested. It is not that we are not able to give the results or the call. Only problem is it becomes the data quality starts to drop.
Right, because we will have DNAs from the booster cells also and from the maternal.
Exactly, sir.
Right. And when we do IVF, we will have DNA from the multiple sperms, because a lot of sperms are attached with the zona.
Correct.
So from there also we will have contamination. So currently it is advisable to go ahead with the ICSI only instead of going for the IVF. Yes. Right. Dr. Sam, another thing what we heard in last 30 minutes, 35 minutes is we require more and more DNA.
Yes.
And we understand as the embryo grows from day 3 to day 4, day 4 to day 5, day 5 to day 6, day 7, we will have more and more DNA.
Correct, sir.
Right? So should we give you samples from the day 6 blastocyst, or should we think of doing the elective culture up to day 7 instead of giving a sample on the day 5, day 6?
Sure, sir. So this is always a very tricky situation, because as we are aware, day 6 is also day for hatching.
Right.
So there is always a consideration, and that is why we took a technology with Malbac WGA, so that we are able to give you results on day 5 itself. So I would say that 99% of the samples I get at Lilac are day 5 embryos. Only 1% of them is day 6. Currently, we are not recommending or mandating extended culture of day 7. It's not required, because in this 99% of our cases, which are all day 5, we have been able to give results. So day 5 onwards, our technology is able to identify and give calls. In fact, with Econ, we did a study where they did a comparison between day 5, day 6 and others. And it's important to note that keeping it in culture for longer yields more DNA. That's it. But it is not necessary that it is mandatory that you go even up to day 6 in this case.
So with the advancement in the sciences, now we are happy with the day 5 culture itself.
Yes, sir. We are able to give, so this numbers which I quoted of, less than 4% failure rate, 99% of those cases are day 5.
And just to extend, just to push you further,
Yes.
Can we give you sample only after day 3? Not going to the other side, but to give you sample much earlier.
So earlier, the problem is the number of cells which are contributing cell-free DNA are very low. So the chances of test failure on a day 3 or a day 4 are much higher than on a day 5. Day 3 especially, sir. So we tried a few cases with day 3. More often than not, we are getting insufficient DNA calls only, because it's a very small representation of the number of cells. You only have 8 to 10 cells on day 3. And some of the cells, most of the cells are very, very actively dividing. So apoptosis is little lower at that stage. Once it undergoes morulation and then blastulation, there you see more apoptosis and differentiation starting to occur in the genome. So there you end up with more cell-free DNA available than compared to day 3.
Recently, I have also come across, to improve the quantity of DNA, we can go ahead with the microfluid system. Is it true that microfluid system of cell culture, embryo culture will give us a better DNA quantity?
Yes, sir. Very, very emphatically yes. Because what happens is, this is a process of active diffusion or trafficking of DNA. So if we are using a microfluidic or microdroplet system, microfluidic is preferred over deep well plate culture, over group culture or very large media usage, simply because it's a process of diffusion. So what happens is, concentration per microliter of media is important. So 15 picograms is sufficient, but if it drops below that, the likelihood of getting this DNA for analysis is very low. So very important to have this microdroplet setup or well setup while doing the culture. This facilitates retention of expelled cell-free embryonic DNA. So it's very important to do that. If we dilute it too much and then give the media for the test, we are not going to have enough of the cell-free DNA for that. Typically, like I put in the last statement over there, we have worked with centers between 30 to 50 microliters also, and we have been able to give them results.
Right. So I'm coming back to the clinical aspect.
Yes, sir.
Can you just tell us a little bit more about there was a big incident internationally which has created a scam about from the Monash, Australia. Let us tell our audience a little bit more about that incident also, because all the people who are doing PGTA, whether it is a TE biopsy or whether it is NICS, I personally feel that all clinicians must know about it. Correct. This incident.
Correct. It is essentially what has happened there, sir. In Monash, the patient was not properly counseled before testing. And I do mean properly counseled, because Monash is one of the leading IVF centers in the world. They have their own set of counselors. However, the patient was not properly counseled before testing and was not made aware that PGT testing, both invasive and non-invasive, has certain false positive rates. The result was that none of the embryos which were screened were euploid and considered for transfer, unfortunately. What is not known is how many of them were flagged as mosaics and not aneuploids. That is the interesting thing. We don't have information whether it was a mosaic or an aneuploid call. And what happened is, later on, from a third party outside Monash, she found out that this is possible, that it could be a false positive call in some of those samples. Therefore, she is claiming that she's denied the right to parenthood by Monash falsely because they advocated this pre-implantation genetic testing screening without informing her or without giving her complete information regarding how the test will work, what are its benefits, limitation, and possible outcome. These three things must be conveyed to the patient before they take up any genetic test, including PGTA or non-invasive PGTA, which surprisingly at Monash, this patient was not made aware of.
No,
How
we must, yeah, please
yes,
continue.
please continue.
Now, what I want to say here, as a clinician,
Yes.
we must be aware of these situations. These many times patients are so distressed when they find there are no euploid embryos, and even though the counselor must have explained them very nicely, I feel even we clinician also must contribute in this counseling, and these all counseling should be documented very well. Otherwise, many times there are so many things which may be routine for us who are in this profession, but for a patient, all these informations may be very vague or Latin and Greek many times. And they don't understand half the things, but they don't want to have it. They just want to have a baby.
Correct.
And by any means, and they don't pay sufficient attention on what we are saying. And later on, when they have failure, when they have not so embryos, that creates all the problem. So all this counseling must be repeated. They should be repeated by the counselor as well as by the clinician, and there should be sufficient documentation with the signature of the couple so that none of us fall into similar situation. This is a very important aspect. Counseling before going ahead with such a sensitive technology is very important. Documentation, signature of the patient is very important.
Exactly, sir. Exactly. So what I would recommend, sir, from my side as a geneticist is that one of the things we drive at Lilac Insights as one of our guiding philosophies is pre and post-test counseling, before and after the test. Both places is very important to have a very thorough, systematic and informed counseling of the patient. So pre-test counseling, typically what our counselors such as Pooja would do is talk about the potential benefits of this, the limitations of the test also. One of the limitations which that patient at Monash should have been very keenly aware of is that it is possible that you will end up with no euploid calls in any of the embryos. If the patient is aware that this is a potential outcome before saying yes for the test, then it is very easy for them to understand that one of the potential outcome is I may not have an embryo available or recommended for transfer after doing this test. So that is one of the things we talk about in our pre-test counseling, talking about the benefits, the limitations of the test and the technology also. And post results also, it's equally important, especially when we are dealing with mosaics. As we often discuss, Dr. Deepak, it is that all mosaics are not equal. So post-test contextualization of the results, because I always emphasize that genetic testing is highly contextual to a case. Each case, it is different. So post-test counseling also is very much required. And at Lilac Insights, since that is our guiding philosophy, we have clinical geneticists with a medical degree, such as Dr. Chaitanya Datta, Dr. Tanmay Deshpande, and we have an entire battery of genetic counselors, such as Pooja and Sutopa, who are there for different zones, who are able to counsel the patient before the test as well as after the test.
So, Dr. Sam, what I understand here, at Lilac, you people have counselors which can help us, even if we don't have in-house counselors who can understand all these aspects.
Exactly.
Even if we don't have clinicians who don't understand all the genetic aspects, you can help us by providing online counseling.
Yes, sir. We can do that, and it's very easy to do that, and it's strongly recommended, sir. I find like some centers would say that counseling is not required or mandatory, but it is very important because, like I said, sir, the context of the test and the outcome of the test need to be explained to the patient very often. Like you said, looking at a report, the patient will not understand. Experts such as yourself will be able to quickly understand it, but a patient typically will not understand it. They just want to know, are there embryos? Can I transfer this embryo or not?
Yes, they understand only the bottom line.
Yes.
Just moving forward to
yes, sir.
Next thing. do we have sufficient data, large prospective blind studies comparing cell-free DNA and TE biopsy?
So,
And
sir, yes,
I think we have already discussed this thing.
correct, sir.
Would you like to add something here?
Sir, so currently there are two clinical trials. One of them is the NICES trial, and we are hoping to see this data because unfortunately, RCTs for PGTA have been very poor in their outcome. So if you look at traditional trophectoderm biopsy-based STAR trials or other studies, they have been very poor in their outcome in terms of how they improve the implantation rate. So even now, any organization in the world will say that there is a reduction in miscarriage if you use PGTA. Whereas here we are looking at the NICES trial. This is a relatively, I use that word very cautiously, relatively newer technology. So we are looking at NICES trial and another trial, looking at the RCT data. And if we look at it, sir, honestly, the problem very often is, since we are looking at the transfers and outcomes, we are very much looking at small scale studies here. I would like to share one of those studies. And it has shown very, very good efficacy, even in a clinical setting. If you look at papers, other papers, they're all lab setting. Even in a clinical setting, we have a paper by Fang et al. In 2019, who has looked at 45 couples here. And intentionally, half this population or cohort was carrying some kind of chromosomal rearrangement in at least one of the partners. So they have intentionally selected 50% of their sample to have a chromosomal rearrangement. And the non-invasive PGTA was the only method used for embryo selection and transfer. Interestingly, what happened is they were transferred and they got a biochemical pregnancy rate of around 72% in the study, then a clinical pregnancy rate of 58%. There were 3 miscarriages after clinical pregnancy, but none of them had chromosomal aneuploidies. And they had a live birth rate of 52%. This is something which we were very, very keen on understanding before we rolled out this technology and this service, that there was a clinical study which showed the clinical application and value of non-invasive PGTA, not just a lab-based study. So we took it into cognizance that there needs to be a clinical outcome study, which is here. And we also are currently working with the various centers on seeing the clinical pregnancy and the clinical outcomes of the embryos which are being transferred using non-invasive PGTA.
Right. Again, I will put a question mark here regarding the sample size.
Yes,
so
sir.
Definitely we are looking for a bigger sample size here.
Correct, sir. Correct. And unfortunately, sir, those kind of studies like randomized clinical trials take a lot of time. They take 2 to 3 years typically. So this year I'm hoping to see some nice data from NICEST. And also we are looking at a multicentric studies in India, because I think Indian data is very poor in this.
Sam, I think you are at the right place where you are getting samples from all over India.
Yes, sir.
And you are already telling us that you have more than 700 samples.
Yes, sir.
So whatever euploids reports you have issued,
yes, sir,
start collecting samples from all of us. And we can have a very good paper here, which will rebuild confidence, which will increase the confidence in the whole technology.
Yes, sir. Because even today I have some anecdotal evidence of around, I think right now 5 cases where we have transferred euploids and 1 case where we have transferred mosaics and there is a clinical pregnancy established. So, but like I said, that's anecdotal, sir. That's not something I want to present as data.
Yeah, 1 case is definitely
yes,
not a evidence.
Exactly, sir.
Right. And regarding coming to the trophectoderm biopsy, as you told, there can be error there also. So how reliable they are? Trophectoderm biopsy results, how reliable they are?
So if we look at it, sir, and does it actually represent the fetus? The answer quite emphatically is no. There is known to be discordance between trophectoderm and inner cell mass. The ICM is far better at clearing aneuploid cells out of it than the trophectoderm, because the fetus has to be euploid. The placenta can have some degree of mosaicism there. So studies where you look at the inner cell mass versus trophectoderm PGTA versus non-invasive PGTA showcase that cell-free embryonic DNA, that is non-invasive PGTA, is a better representative of ploidy. So trophectoderm biopsy must be taken with a grain of salt when you're analyzing it, especially aneuploid or mosaic calls. We need to be very cautious. Euploid calls are okay, but aneuploid calls, it's very, very important. And there are some interesting papers, again, very small cohort papers here. This was a paper which I wanted to put up because this is published in PLOS. And this is a paper which looked at the same phenomenon. And they looked at embryo correction. They tried to mimic it in the lab with whatever means they found. Again, this is a Japanese group, Shitara's group, this is. And what they did here is they took a small set of 20 embryos and did a comparative analysis. And rather than going through the entire data, I will show one data here very interesting. You look at case number 1, it was a very good embryo, 4BB, age 35. So on the borderline for advanced maternal age. On day 5, non-invasive PGTA was done and PGTA was done. Unfortunately, results between PGTA and non-invasive PGTA are discordant. Non-invasive PGTA is saying this is euploid embryo. PGT is saying aneuploid embryo, trisomy 14, please discard. So they continued culturing this embryo up to day 10, sacrificed the embryo, looked at the inner cell mass. And on day 10, they're seeing that this embryo is perfectly euploid. So on day 5, if you had done PGTA, you would not have even preserved this embryo, or you would have preserved it and not kept it for transfer. You would have not selected. So it's a clear case of a false positive coming from PGTA, simply because trophectoderm tends to have more amount of live aneuploid cells. It harbors it. The clearance rate is very slow in trophectoderm compared to inner cells. And across the board, if you look at the performance here, the sensitivity, specificity, positive predictive values, negative, interestingly in this paper also, negative predictive values also significantly different. And if you look at the false negative rate in non-invasive PGT in this particular study, it's 0. And why I put this is an example, Dr. Deepak, but more and more literature is showing a similar trend. Because every center is doing a single center study where they have to sacrifice the embryo, unfortunately. And but you see this pattern that the false positive rate in non-invasive PGTA is far lower than that of PGT.
Right. Very, very important. Moving forward,
Yes,
pushing it forward, do we have sufficient data about the NIPGTA that it improves the implantation and decreases the abortion?
Yes, sir. So one of those papers which I showed recently, the paper with the clinical study with the 52 embryos, 52 couples, is that you get a live birth rate which is similar to what you see. Around 52% was the live birth rate in that clinical study, that pilot clinical study. So this is the current available data. That is one of the largest studies which has been undertaken. That also was a multi-year. It was a 2-year study, which I just presented earlier in the slides. So that is one of the driving studies. More data is expected from RCTs, which is going to be the ultimate test of non-invasive PGTA. Currently, data is very isolated, unfortunately, Dr. Deep, because very few service partners have done multicentric studies.
So we have long way to move forward.
Yes, sir.
Coming to the mosaic, go back to the previous slide. Yes. Coming back to the mosaic issue, many times you have given this report of mosaic, creating enough confusion among us, among the patients. So do we face similar issues of mosaic with the TE biopsy? And what do you mean by intermediate results? Sometimes we talk about, you people give us the result, low level mosaic, creating further, forget about the mosaic confusion. To add a little bit more confusion, you talk about low level mosaic and the high level mosaic. Yes. Please tell us more about it.
So, sir, one of the important things in both in trophectoderm biopsy as well as non-invasive PGTA, you get mosaicism. So this is a fact. Both the technologies, or both approaches, I should say, technology is similar, give you mosaic results. In non-invasive PGTA, the chance of getting a mosaic is a low-level mosaic. Very precisely, a low-level mosaic is slightly higher, simply because in non-invasive PGTA, you have a mixture of trophectoderm plus inner cell mass.
Now, what do you mean by low level? Sorry to interrupt you, but what do you mean by low level mosaic?
It's a very important question, sir. So typically low level mosaics are considered between 20% to around 60% are considered low level mosaics. So if you see something which is 70%, 80% in the chromosome, typically we flag it, especially if you see multiple chromosomes, as an aneuploid. So if you look at the PGD International Society guidelines, there is a very clear way of classifying this. And this is the guideline, international guideline, which we follow. And it's very important to note that it is not just percentage mosaicism, Dr. Deepak, it is which chromosome is involved and is it a monosomy or trisomy. That becomes very important. And that is where the reporting expertise becomes important, because the artificial intelligence of any software just flags it as aneuploid or euploid or mosaic. But this additional stratification of analysis, this additional layer of analysis has to be done by somebody who has expertise in analyzing NGS data and reporting it. And so that's why I mentioned in the third point, not all mosaics are equal. It's very important to remember that. And if you are transferring a mosaic embryo, it is very important that a invasive confirmatory test is done. This is according to American College of Medical Genetics and Genomics guidelines, that if you're doing a preconception test, once the embryo implants, becomes a clinical pregnancy, once it reaches 12 weeks or 14 weeks, first choice should be an amnio, if not a CVS. First choice should be an amnio. And then we should do either a karyotype or a low resolution microarray to rule out any aneuploidies when you're transferring mosaics. When you're transferring euploid, it's not mandated, but when you're transferring mosaic, it is recommended.
Just to extend further on this issue about the euploid embryo. When we transfer euploid embryo, after confirming with the NICS, this is the euploid embryo,
yes, sir.
Do we need to do down screening?
So, sir,
in the prenatal cases?
Yes, sir. Yes, sir. So this is a case, sir. Actually, before I get to, I'll talk about that, sir. This is one case. So why I'm talking about this is that when I said not all mosaics are equal, the doctor doesn't, in this particular, it's an actual practical case, sir. Doctor doesn't have a single embryo which is euploid. They have one aneuploid and two low-level mosaics. And both the low-level mosaics are in the sex chromosome aneuploid here, because it is in the N. N is the sex chromosome. We mask it. So here, what we have done for the doctor and what we do with our expertise is we actually give a transfer preference, which should be done first, which should be considered second, or if they're transferring both, that is up to them. But if they're doing selective single embryo transfer, which one of the two low-level mosaics should be considered for transfer? We even stratify it and we explain why. If you look at CTE2, it's a very small part of a chromosome which is showing mosaicism compared to the CTE1 where the entire chromosome is showing mosaicism. So depending on the size, the location, whether it's a monosomy, whether it's a trisomy, following this PGDIS guidelines, we do it. This is one of our own case. Sir, if you'd...
yes, I can recall.
Yes, sir. So even though here it is a low-level mosaic, it's only a 50% mosaic. It's not a 60%, 70%. Since it is trisomy 21, based on our discussion, I always recommend this embryo for transfer or keep it as a very low priority for transfer because it is trisomy 21. The chance of having an affected child here is much higher. So,
right, I can recall this case very nicely. In fact, the PGDA guidelines were very helpful in this. Yes. Can we have a quick slide? I think we have a slide on PG. These guidelines are amazing, and I feel all the clinicians, all the embryologists must be familiar with these guidelines. A copy of these guidelines. I have pasted these guidelines in my chamber, in my counseling room, and these guidelines, especially this particular slide, is available with all our consultants. Whenever whoever is doing sending a case for the PGT, NIPGTA, all of them has these guidelines, and this is very useful.
Yes, sir. So this is the guidelines even we follow in classifying embryos as low-level mosaics, high-level mosaics, or aneuploids. This is what exactly the same guidelines. So that's why I said, Dr. Deepak, that all chromosome mosaics are not equal. Some of them are much high risk.
Yes, and when we don't have any euploid embryos, and many times patient insist, sir कुछ तो कर दो, एक तो transfer कर दो, ये वाला कर सकते हैं कि ये वाला कर सकते हैं. So at that time, these guidelines is a written documentation also, guiding line for us as well as a counseling instrument for our patients also. Look at these data, and which says that if we transfer this type of embryo, we can have an unpleasant outcome. So let's not move forward, or let us move forward with the amnio option in the future. So these are very important.
Yes, sir.
And another thing, is there any risk of hypertension following T biopsy or
non-invasive PGT? Yes, sir. So interesting. It's a very important question you asked, because recently, I think this is a 2021 paper which I came across. In non-invasive PGT, no, sir, because we are not perturbing or disturbing that embryo in any way. We are just collecting media which contains normally expelled DNA, So it does not harm the embryo. But interestingly, in a trophectoderm biopsy, there have been some very, very key observations which have been done. There was a retrospective study which I will be presenting in my next slide, that there is an increased risk of monozygotic twinning, 3.5% versus I think 0.5 or 0.6% without biopsy. And as you are aware, monozygotic twins are a complex pregnancy to handle, especially when you consider things like twin-to-twin transfusion syndrome. And I have spoken to clinicians across India where they say, yes, Sam, we have done this. We have transferred the embryo where we have got a monozygotic twin, and that led to a lot of complications, and the pregnancy could not continue.
Yes, even we have similar experiences. Just want to add one more thing.
Yes, sir.
Whether it is NIPGTA or TE biopsy, as such, the procedure, both the procedure in themselves does not increase the chances of hypertensive disorders in pregnancy. It is the way we prepare our endometrium for the transfer that makes a difference, whether we go for the stimulated cycle or whether we go for hormone HRT cycle. In HRT cycle, we will have more chances of hypertensive disorder. In stimulated cycle, we will have less chances of hypertensive disorder. So practically, both these techniques are benign and does not causes increased incidence of hypertensive disorder. Yes, as Dr. Sam told us, the chances of monozygotic twins increases following TE biopsy, which risk is not there with NICS.
Yes, sir. So this is the study where you have 3.5% cases of TE biopsy resulting in a monozygotic twin versus 0.8. I'm sorry, it was not 0.6 or 7, 0.8% where it happened without a biopsy. So it's a very interesting study, I think. And after this study, a lot of our Western counterparts also looked at non-invasive PGTA much more keenly, because managing a monozygotic pregnancy is always complicated.
And the chances of complete failure in these pregnancies is also, we cannot ignore.
Yes, sir.
Ultimate target is always a successful delivery, successful healthy delivery.
Yes, sir.
And moving forward,
yes, sir.
After NIPGTA, can we just ignore the morphology? Suppose we have a grade 3 embryo, but it is showing euploid embryo. So can we just ignore the morphology altogether?
So with my experience of more than 5 years in this field, sir, I would say no. Morphology and genetics go hand in hand even today. Although they will not always agree with each other, but they both go hand in hand. We must get a snapshot of the morphology, because that also looks at other factors. The metabolic activity, for example, in the embryo is determined by morphology, how good the embryo is, how well developed it is. So that is also a very good indicator for the overall embryo health. And at this point in time, I would say that it is not good or not advisable to recommend it. And active embryos also, we have seen, generate more CFE DNA. So metabolically active embryos, morphologically good embryos, tend to generate more CFE DNA, be it euploid or aneuploid, but they do it. So typically we look at grade 3 plus embryos for testing in non-invasive PGT.
Right. Moving forward, I think few of the questions we have already answered. Yes, what's your next question in your slide? Is there any role of...
I think this we have answered.
Answered. We can move forward. We are running short of time.
Yes, sir.
Are we discarding too many embryos? Yes, we have answered. You have already answered this also. You have answered this also. Yes, this is important. Yes. There were few questions which were raised. Does recovering DNA from the spent media decreases implantation rate? There were questions whether this DNA in the spent media helps in the implantation.
So, sir, very importantly, there is very little evidence for this, that it actually influences implantation. And what happens is, when you vitrify your embryo, most of the CFE DNA is left behind in the spent media. So it's not going along with the embryo for vitrification and then for transfer. So it currently is not established that it plays a major role. And as a geneticist, although this is seen that, on day 5, closer to date of implantation, more CFE DNA is coming, this could just be an artifact of a fact that more apoptosis is also happening.
Exactly.
More apoptosis is happening, the embryo is becoming ready for hatching to emerge out of the zona. So you have more apoptosis happening. As a result, you have more CFE DNA. But its role in implantation is not well established. And like I said, in the IVF setting, since we are transferring the embryo out of the spent culture media into vitrification, most of the cell-free embryonic DNA anyhow tends to
Left
remain
behind.
in the media.
Left behind. Right.
Yes.
Right. Moving forward. About the, till now we talked about the aneuploidy screening only.
Yes, sir.
Can we go ahead with the diagnostic test? So that's a monogenic structural rearrangements with the NACS?
So, sir, monogenic currently no, sir. And why I'm saying no is not because technology is not capable, it's not validated. So it's very important if anybody approaches you
Right.
saying, I want to do non-invasive monogenic testing, please ask them for validation data or published peer-reviewed data. Currently, it is not available, although the technology can do it because I'm sequencing DNA. So I'll be able to pick up mutation. Currently, since it is not clinically validated, we are not recommending it to them. For translocations, sir, again, extremely specific. For whole chromosome Robertsonian translocations, it can be considered. So for any translocation case, Dr. Deepak, you would send it to me and the counselors. We would do a workup for you. I'll just show you an example after this. We will do a workup where we actually give you the possible outcomes. And then we will recommend whether to go for invasive PGT-SR with a biopsy or do a non-invasive PGT. So last point which you had asked earlier, I'm sorry, I'm answering it a little late.
Yeah.
Down syndrome screening, sir, whatever is there, routine screening like double marker, NT, all this should be done even if it is euploid in non-invasive PGTA or PGTA. So routine pregnancy screening cannot be ignored just because the results have come as euploid. Although it is not necessary that once you transfer a euploid called non-invasive PGTA or PGTA embryo, that you have to do mandatory invasive confirmation. That is mandated for mosaic embryos, not for euploids.
Right. Sam, before we close down, we have few questions.
Yes.
One question we have from Rupali Tambe from Pune. So she's asking, as NICS is a screening technique,
Correct.
it's not a diagnostic procedure. So if the test result comes as a positive, the embryo is aneuploid.
Yes.
Do we have any confirmatory? Do we need any confirmatory test following
It is
this?
not mandated, sir. It's not mandated. However, if you would like to do a follow-up trophectoderm biopsy, it should be remembered that even the trophectoderm biopsy is not an accurate representation. It may have discordance.
So with the current situation, NICS, following NICS, no further tests are recommended, though it is a screening test.
Though it's a screening test, it is not mandatory that we do a biopsy for confirmation. However, if the center would like to send a biopsy to us for us to analyze it in parallel, that can be done.
Okay. Another questions we have from Dr. Saurabh Maheshwari from Guwahati. Is polymorphism in the parents, one of the parents, is an indication for the PGT?
So, sir, if it's a heterochromatin polymorphism, if it's a simple heterochromatin polymorphism, it is not an indication for PGTA as well as non-invasive PGTA, because heterochromatin typically does not contain actively coding genes, or it is mostly repetitive DNA. And polymorphic variants on Y chromosome, on chromosome 13 and others are commonly seen in the population. So it is not an indication.
Sam, here I would like to have your opinion.
Yes,
here in clinical practice, we very often see patient with Y chromosome polymorphism 13, though we call it heterochromatin, but they often come with the bad obstetric history or unexplained infertility.
yes.
In fact, we have sent you few samples where they have shown the heterochromatin polymorphism, and the results were plenty of aneuploidies. So though the clinical data doesn't say, but our experience says something different.
Yes, sir.
So anything, any comment on this from your
So, sir,
side?
I would agree with you, sir. Even for me as a geneticist, it is a very big concern, because even if you look at natural pregnancies along with IVF pregnancies, you see a higher miscarriage rate in some of the polymorphisms. But the problem is the correlation is not very direct, sir. And there is no established correlation. That's why at this point, I would say that if you are finding this correlation in the clinic, then it is better and more prudent to offer a screening such as non-invasive PGTA to rule out gross aneuploidies. Because what is happening, like you said, Dr. Deepak, although the indication in the parent might just be a simple polymorphism, in the embryo it could be a absolute completely aneuploid result. So that way, yes. But in terms of looking at large data, the direct correlation is not established.
I think, Dr. Saurav, you have to publish some data on this. I know that you are collecting data on the polymorphism and the outcome in the next generation. So it will be very nice if we can publish some data. Dr. Saurav is one of my colleagues from IHR Guwahati only. We have one more question from the Dr. Singhu Bala.
Yes.
What are the expenses for this?
So
Bottom line.
Yes, sir. Bottom line. So typically what happens in this case, and very often, very honestly, Dr. Deepak, I prefer talking more technology than cost. But typically this ranges on the number of samples you're giving us and, you know, the how many samples you're going to be sending, because there are always additional costs when you're doing preconception testing.
Let me things make easier for you. let me share how much we charge from our patients.
Yes,
we charge 20,000 rupees per sample from our patients.
Thank you, Dr. Deepak, for helping me out. very, very strange to answer that particular question.
I can understand asking this from a technical person, from a scientist. It will be difficult to get an answer. That's why I overtook from this liberty. So we charge 20,000 rupees analyzing per embryo for the what we give to Lilac, or our own expenses, our embryologist, our technical expertization, our expenses on the laboratory. We charge 20,000 rupees for per embryo analysis. This question was from the Bala Singhu from Siliguri. Yeah. Let's moving forward. This is the last, I think, question. I think we have already discussed this.
Yes, sir. Sir, yes.
Yeah. Where do you see the future of NIPGT?
So, very interestingly, we are talking on a Sunday where I have a new update for you. So one of the benefits of doing this is it's non-invasive, doesn't require a laser, gives you access to inner cell mass DNA, and it's very low in terms of sampling time. Where I see the future is looking at things like monogenic analysis. Can I do a monogenic disorder screening through non-invasive PGT-A? Because it's DNA coming from the embryo. So I should be able to do it, and I should be able to analyze it and report it. Today, I think we are having a upgrade of the ChromeGo algorithm, and there is some insights we are getting about mitochondrial DNA as well. So, but unfortunately, mitochondrial DNA and its quantification is another story. But at least mitochondrial DNA analysis should be possible in the next few months with spent media, non-invasively. And my own favorite or my own passion is about, you know, giving you comprehensive answers. So I am looking more at terms like things like combinatorial analysis, looking at genomics and biochemistry to give you a snapshot of the embryo. So I feel that the media, spent media, should be able to give us a snapshot of the embryo on day 5 or early day 6, whenever we are sampling it, both in terms of its genetic makeup and its metabolic competencies, because these are two very important factors which determine the implantation potential of an embryo. So I'm looking at that also, and at Lilac, we are starting some work on looking both at genomics as well as some biochemical parameters on spent media.
We have a feedback from our embryologist, Rashmi Goenka. She has just given us a feedback that as per her experience, even grade B blastocysts after NICS has given them successful pregnancies.
That's
so not necessary all the embryos has to be grade A.
Correct.
Even grade B blastocysts, we can go ahead with NICS, and we can move ahead. If the embryos are euploid, we can move ahead and go ahead with the transfer. And that gives us a successful deliveries, pregnancies and deliveries. Thank you. I think this was our last slide.
Yes, sir.
Sorry to interrupt.
Yes. Thank you, Dr. Sam, and thank you, Kunal. Thank you, Chirag, for helping us to understand this whole technology in a much better way. Dr. Pooja, would you like to add? Would you like to sum up the whole thing?
So actually, see, I'm a genetic counselor, so listening to it, I think it is very important for us also to understand like what goes on behind the scenes. Because when we are explaining to the patients as to why a particular embryo is going to work out for them or why one may not, it is important for us to know where we are coming from as well. So I think this was a very interesting and very enriching discussion, even for all counselors like me. So and especially like the fact is, these were all questions that were collected, right, over a period of time with your experience. So that made it a little more like a real life kind of live
In
experience.
clinical context, it's a clinical
Yeah.
setting in which
Yes.
Going forward, when we are also going to face a lot of these scenarios. Like everybody listening to this at some point in time is going to listen to, is going to come up or face any such scenario. So I think it was a very good discussion. And thank you so much for.
Thank you, Pooja. We have one more question from Rashmi Harsal. Should we send sample for the poor quality embryos also? Keeping the cost factor in the mind, should we do NICS only for the grade A or grade B, or should we go ahead with the NICS of grade C also?
So,
Personally,
sir, typically,
yes, I'm.
yes, sir. Typically, what is this? Grade 3 plus expansion. It can be a double B, it can be BC also. That does give results. So when you have very poor grade, it's not expanding, it's not active, then I would recommend certain caution in sending a sample because the chance of failure is higher. But if it's a good expanding embryo, even if it is not a grade 4 embryo or a grade A embryo, it can be sampled.
I hope that answers. We don't have any more question. With a positive note, hope to see you more and more in our future endeavor. We can conclude here. Thank you, all of you, once again for sparing your Sunday morning with us. Thank you.
Thank you, Dr. Deepak. Thanks, Pooja.
Spent Sunday. Thank you, Dr.
Thank you, everybody. Have a nice weekend. Bye.
Bye-bye.
Thank you. Take care.